Hello and welcome to our March 2021 LabCoP session. My name is Anafi Mataka, and as usual, I'm delighted to be your host today. Apologies for the late start. We just wanted to give an opportunity for colleagues to join. Strangely, there is a little bit of confusion with time between the calendar invite as well as the time on Zoom. I believe we have a sufficient number of people to start, so apologies once again. Today we have an exciting topic in which we have Dr. Lara Vojnov from WHO, from her role as Diagnostic Advisor, to give us the updates on the new WHO recommendations for clinical and service delivery for HIV prevention, treatment and care. After Dr. Lara Vojnov has given us the new updates, we will call upon Mr. Moses Supercharger Nsubuga from Uganda, who is going to also give us some commentary on what this means from the perspective of the recipients of care. As usual, this will be a 1 hour long session. We shall start with those presentations and followed by a Q&A session. Remember to put your questions and comments into the chat box, and we shall attend them as soon as the presentations are done. So sit back and relax, and hopefully you enjoy the session. Dr. Lara, over to you. Kind reminder that interpretation is there from English to French, so please choose the language of your choice. Thank you.
Great, thank you so much, Anafi. Hopefully you can both see my slides and hear me, as well as see me at this point now. So as Anafi says, I'm going to talk today a little bit about some of the WHO recommendations that were released just a couple of weeks ago now on some key clinical and service delivery diagnostic considerations in particular. This session was actually relatively heavy on diagnostics, given that we thought that there were a few key items that we really wanted to touch on and review, given some of the recent evidence that's been developed. There are 5 key questions in particular that we looked at over this recent session that took place in the fall of last year, and like I said, has just been released, and I'll share with you the web address that points to the updated guidelines. There are 3 questions in the clinical space. First, on point of care infant diagnosis, as well as viral load. We reviewed the treatment failure algorithm and wanted to think about it a little bit more in terms of being forward thinking about some of the new regimens that are now being utilized in people living with HIV, particularly those optimized regimens such as dolutegravir-based first-line treatment. We looked at 2 service delivery questions as well. One is around task sharing of specimen collection and point of care testing, and the other is looking at diagnostic integration. And that's a key topic that we've spoken about in these webinars quite a bit frequently in the past. So when I start with infant testing, the first thing I really want to highlight is thinking about the algorithm now more in a process. Previously, countries have really focused on the 6-week infant test, and we really now want to encourage a little bit more of a comprehensive and long-term view, knowing that infants can continue to be at risk of transmission through the period of breastfeeding. So we now have a multi-nucleic acid algorithm. It starts with birth testing, of course, where that's of value. It's a conditional recommendation right now as we await further evidence. We still have that 6-week test that's very important. We've changed the 9-month test from a rapid test now to a nucleic acid test, and there is some documentation to support that change. As well as ideally any time an HIV-exposed infant presents to the healthcare facility while they're sick. 2 other really key components that we feel are important to touch on and highlight is number 1, ensuring confirmatory testing is done when you get a first positive nucleic acid test. So of course that infant should be started onto treatment while that second confirmatory test is being done. And then of course the diagnosis isn't complete without that final diagnosis at the end of the period of risk for transmission. So ideally, that would be done at 18 months or 3 months after cessation of breastfeeding, whichever is later. Of course, if an infant is positive at any of these time points, then we consider that a definitive diagnosis. Ideally, would be started onto treatment and followed up thereafter. Now, we wanted to understand where some of the gaps and challenges have been within this algorithm and within infant testing. And we're starting to call it now infant testing rather than EID specifically, because of course, it's a long-term algorithm, whereas early infant diagnosis really focuses on the birth and the 6-week testing primarily. So we held a systematic review looking at lab-based infant testing to really understand, like I said, some of those challenges. And though we've seen the majority of test results are being provided to caregivers, about 77%, and that the mean age at the testing time point was about 74 days, what we see is a considerable lag until the time for treatment initiation, where the mean age seems to typically be about 7 months of age. And where we see some of the gaps in this case is when you look at the left-hand figure, there's quite a considerable amount of time, as we've been calling it, a turnaround time between a DBS sample being collected, it being run in the lab with that transport to the lab, and then the result being returned to the facility and then subsequently being returned to the caregiver typically takes about 45 plus days. And the issue with this is that the HIV exposed infants are typically very vulnerable. They have high morbidity and mortality rates. And here you see the peak of mortality is typically at about 2 to 3 months of age. So the caregiver can often actually get the result after that peak. And that actually does seem to translate to some of the review data that has come out, showing that about 15% of HIV positive infants have died between that testing period and ART initiation. In 2016, we made the recommendation that point of care nucleic acid technologies can be considered for infant diagnosis. But at that point, we really only had 2 diagnostic accuracy studies. Since then, since 2016, there have been a plethora of evidence that have been released, including clinical impact, cost effectiveness, et cetera. So we felt last year that it was really timely to review all of the updated evidence and take another look at this recommendation. When we looked at, then we had a systematic review done on the clinical impact of point of care, of same-day point of care infant testing. Now it's more about when the result is delivered than the actual technology specifically itself. What we found was that infants were 8 times more likely to start treatment within 60 days when you provided a same-day point of care test compared to standard of care testing. We had about 93% actually that started within 60 days using point of care, only about 50% with standard of care. And this is across at least 6 or 7 studies that have been conducted thus far. Fortunately, using same-day testing, the time to ART initiation was typically a median of 0 days with point of care, but about 40 days with standard of care. And using same-day testing allowed for same-day ART initiation much more so than the standard of care. And again, just reiterating the vulnerability and the high morbidity and mortality rates of these very specific key population. We also wanted to look at a few other key aspects. Of course, within our guidelines, we don't just focus on the clinical impact. We also look at the cost effectiveness and affordability and a few other pieces I'll touch on in the next slide. And this might be a little bit busy. I would just suggest that you can refer to it while we share the slides later. But essentially, a number of different cost effectiveness studies have been now published that have shown that point of care infant diagnosis is cost effective, even if the technology itself and each test is a little bit more expensive. The benefits that it brings results in that cost effectiveness and in some cases cost savings. And that case in particular is when we start to think about integrating the programs, the infant diagnosis program with other programs such as viral load or even TB in some cases, where some of the device costs as well as others could be amortized across or could be shared across the different programs. And similarly, we found that it was somewhat affordable, particularly thinking about how you would optimize implementation of these technologies to ensure that same-day testing. Of course, we don't necessarily expect that every single infant will have access at this stage. Ideally, we'll start to expand that access, but even if we provided 70% of infants with access to same-day testing, that would result just in 4 countries alone, about 40,000 infants who would be initiated onto ART, whereas they otherwise might not with standard of care, at just over $300 per additional initiation. So quite affordable, it seems, as well. We also wanted to understand the acceptability, particularly for people living with HIV, the feasibility of potentially doing so, knowing that there are some challenges of implementing new technologies, as well as any ethical considerations that could be raised. We found that people living with HIV were typically very welcoming of this technology and having same-day results, particularly as this gave them some peace of mind. They knew much more quickly whether their infant was positive or negative, and then could provide the right clinical support for them. When we looked at the feasibility, one thing that was interesting, and I'm just highlighting one country here in this graph at the top right, is that it seems that infants aren't necessarily equally distributed across healthcare facilities. And what we see is that a significant proportion of infants actually present to a small number of healthcare facilities. In this representative example, we see that 80% of HIV-exposed infants are actually presenting only to 33% of sites. So we could actually access 80% of those infants by providing these types of same-day technologies to only 33% of the healthcare facilities in this country. Now, when we also think about some of the ethical considerations, we had a bioethicist review this question and some of the available evidence. And he suggested that effectively there's no clear reason not to scale up and implement point of care infant diagnosis, and ideally really encouraging the whole global community to work together to support countries in doing so, given the value and impact of that. So based on all of this compilation of evidence, and of course you can read more in our guidelines that have just been released, the guideline development group felt that it was fair and right to strongly recommend the use of point of care nucleic acid testing to diagnose infants and children under 18 months of age. Of course, there's some considerations that we really want to ensure, and particularly around the implementation aspects. Number one is that testing, whether it's infant diagnosis, viral load, or others, are only as good as having the clinical systems in place to support and make decisions based on those results. So really strengthening, encouraging strengthening of ART initiation services for this critical population. Of course, we're thinking now that this isn't necessarily just for the 6-week test, but for any of the nucleic acid tests that are suggested within the infant algorithm, point of care should be considered. Of course, we want to also continue thinking about and improving our overall diagnostic system, including lab-based technologies, and how we can expand that across diseases and think about integration. And I'll touch on that a little bit more later. And of course, there are other key components that are always necessary. It's only in one bullet, but sometimes these are most important in ensuring human resources, training, data management, quality assurance, etc. Now, when I shift a little bit to start talking about and thinking about treatment monitoring, really, I want to touch on 2 things, the viral load in general and point of care viral load, as well as the treatment monitoring algorithm. I'm sure you all know it well, so I'm not going to go into too much depth in this slide. But one thing to note is that we've seen considerable scale up of viral load testing in particular across all of your countries. It's been quite impressive over the last few years, but we continue to see some challenges. And some of these challenges in particular around infrastructural barriers, long test turnaround times, which is quite similar to the infant diagnosis challenges that we've seen, as well as clinical utilization of results. And I know we've spoken about that in previous sessions, really ensuring that it's great that we continue to scale up and do as many tests as possible, but we want to be sure and making sure that those tests are actually used to support people living with HIV. So when we focus particularly on the first question in this area, looking at point of care viral load, we again commissioned a systematic review. There aren't as many studies yet, but we do know of a number of additional studies that are ongoing to support and look at the impact of this intervention. But even from the few studies that we have seen thus far, we do see that point of care seems to improve the turnaround time of results coming back to the patient by as much as 17 times, as well as it reduces the time to a clinical action, particularly for those with an elevated viral load, which is obviously a very important population. We also see a few additional clinical benefits, including the turnaround of time of results to the clinician, the probability that a person living with HIV would get a same-day result, and the probability of receiving and reducing the time to differentiated care for those who are undetectable. Interestingly, one study also showed that having same-day point-of-care viral load testing improved retention in care and viral suppression at 18 months. So based on these evidence, as well as some of the cost-effectiveness summary and a few of the other components that I won't go into too much depth today about, but you can again refer to it in the guidelines, the group felt that it was the right time to make a conditional recommendation that point-of-care viral load could be used to monitor treatment among people living with HIV who are receiving ART. Now, one important consideration and a couple of rationale for why a conditional rather than strong recommendation was made. Number one was around considering the costs, and that currently point-of-care technologies typically are more expensive than lab-based tests, but also that the throughput may not allow for every person living with HIV to receive a same-day viral load, as well as, of course, especially if we're providing infant diagnosis and TB testing on some of the same devices. They felt the real need to highlight some key populations and priority populations that they felt should be receiving point-of-care viral load and should effectively be prioritized if you do have some space on those technologies. And those are in particular to try to provide a same-day point-of-care viral load to all pregnant and breastfeeding women. And of course, this is for their own health, but also to try to limit transmission to their infants. For infants, children, and adolescents who particularly have high rates of drug resistance and who may be in need for rapid clinical interventions. And then people requiring a repeat viral load test after that first elevated viral load were three of the top populations that the group felt should, as much as possible, be receiving same-day viral load testing. Additionally, we could be looking at those for whom treatment failure is suspected, those who present sick, and then those who require a viral load after re-entering care. So that first viral load at about the 6-month time period. When we start talking about the treatment failure algorithm, we really wanted to reflect on 4 key questions in this space based on the 2016 algorithm that was published. Number 1 was around the timing of the first viral load. Currently, we suggest that it be considered at the 6-month visit after ART initiation. We wanted to understand whether that should be earlier or not. We also looked at the timing of the repeat viral load after the first elevated viral load, which currently, or in 2016, we suggested to be 3 to 6 months after that first elevated viral load. But there was a new consideration for thinking about immediate or a single viral load switch to second line for those patients who are on NNRTI-based regimens. So if they have an elevated first viral load, should they right away be put onto second line treatment? And then, of course, revisiting the treatment failure threshold, which I think has been spoken about quite a bit over the last couple of years. And we also thought about whether we should have a separate threshold for suppression and undetectable to indicate that more clearly, that they're not one and the same, those 2 thresholds. So when we take a look at the updated treatment monitoring algorithm, I'll walk you through this, in particular, those 4 key questions. So in the very top box, that star there, that first question of the timing of the first viral load, we now suggest that that first viral load be done and the result be ready at the 6-month time point visit after ART initiation. So rather than taking the sample at that time, ideally the sample would have been taken at the visit prior and the result being ready to be reviewed and discussed. The group wasn't ready to shift that timeline to 1 month or 3 months, but felt it was right to start having the clinical conversation with the person living with HIV at 6 months. So ideally, the result would already be ready by then. When we talk about the second question, which is when that repeat viral load should be done after the first elevated, the bottom red star you see here, we've tried to tighten and clarify that timeline a little bit more and suggest that the repeat viral load be done at 3 months after the first elevated viral load. With the third question on whether we should be considering an immediate switch to second line or to the next appropriate regimen, we do now suggest that people living with HIV who have a first elevated viral load above 1,000 copies per ml can be considered to be switched to another appropriate regimen. And this is only in relation to those on NNRTI-based regimens. So those who are on dolutegravir-based regimens, this would not apply at this point, primarily because we do not see the same levels of drug resistance as we do for NNRTI-based regimens. Lastly, when we look at the treatment failure algorithm, the group felt that it was still pertinent to keep the treatment failure threshold at the 1,000 copies per ml. So only if you have that, an elevated viral load above that level, would you actually switch therapy. But they did feel it was worthwhile to highlight and indicate what undetectable really meant, to indicate that that is the end goal for people living with HIV and their clinicians, not necessarily having less than 1,000 copies per ml. And so we've now defined undetectable to be what it actually means, is undetectable, generally less than 50 copies per ml. We also wanted to provide a little bit more clinical monitoring to those patients who have a detectable viral load that is less than the treatment failure threshold. And so we still suggest adherence counseling for them and follow-up viral load to try and ensure that they are bringing their viral load down to undetectable levels. And so we have not moved to necessarily suggesting that those with low-level viremia be switched to a next regimen. And that's primarily because we still don't know the relevance of low-level viremia for those on dolutegravir-based regimens. And we still haven't seen very much drug resistance in those populations. So ideally, we really want to be ensuring that those on optimized ART, particularly dolutegravir-based regimens, are maintained on those as long as possible, given the efficacy that we've seen. Now, we've made a few implementation considerations for pregnant and breastfeeding women. I'm not going to go into this in detail, but of course you can refer to this in the guidelines. Essentially, we're trying to provide a little bit more guidance, even though the evidence has not yet been developed, to highlight certain time points when we think it would be useful to do viral load testing for pregnant and breastfeeding women for their own care, but also to try to reduce transmission to their infants. So please take a look, and we're always here for any questions that may arise. Now, when I shift to the service delivery questions, and I'm nearly done with these last two questions in particular, in 2016, we put out a good practice statement suggesting that trained and supervised non-lab staff could undertake finger prick sample collection. In 2019, we made the recommendation that lay providers could also do rapid diagnostic tests of HIV. We've had in the interim since 2016 quite a bit of evidence come out comparing both sample collection and point of care testing by non-lab staff compared to lab staff performing the same tests. And that's across the board, looking at CD4, infant diagnosis, a little bit of viral load, but also some additional tests, HIV-related tests that we feel are also really important. And based on these new evidence, the group felt that we could make a strong recommendation to suggest that task sharing of specimen collection and point of care testing for with non-lab staff should be implemented in particular when professional staffing capacity is limited, and that can be the case in many countries. Now, finally, I wanted to touch just quickly on diagnostic integration. And this is a piece that we've been working quite closely with ASLM and others to think about how we can integrate our diagnostics across programs, effectively sharing our devices, but also starting to think about sharing the systems that we need to put in place to support our diagnostic networks. When we think about sharing devices in particular, of course, some of the key components there are around sharing costs and resources to ensure that everyone is benefiting from doing so. We really need to be thinking about network optimization. I know this has come up a number of times in terms of how to place and think about what the needs are across different healthcare facilities. And it links a little bit with some of the patient considerations and ensuring each of the different programs are having their needs and their volumes met while not overloading some of the current devices, both on the lab-based side as well as the point of care side, because of course, some of the initial host systems, such as the TB programs, should be able to fully test their patients. And it's about how we can support them and work within that network. Of course, beyond just sharing the actual devices, ideally, we'd like to be starting to think about some of the systems that we could think about sharing, including sample transportation, supply chain, quality assurance, et cetera. And ideally, this would set up a nice example and framework for service integration in general, which has been quite a hot topic. We have a couple of documents that I've posted on the right-hand side that might help in continuing to think about some of these considerations. So based on this, as well as some of the evidence that's come out that's really indicated that integrating across especially TB and HIV, and when we think about adding some of the HIV tests, particularly to TB procured technologies, we saw in a couple of the studies that they did so quite deliberately. So thinking about, of course, infant diagnosis is one of the priority populations, but then targeted viral load as opposed to necessarily having everybody be tested, really allowed for not exceeding the capacity of those current devices and not impacting the TB services. And in concert, that really helped the HIV programs to have faster and increased rates of clinical action, both for HIV positive infants and for people living with HIV. And on the right-hand side are a number of technologies beyond just the ones that were studied that are available for consideration for integration, that have a number of tests available that can be shared across disease programs. And though often we talk about one or two technologies, in particular, the Gene Expert, I think it's also really important that we focus on and think about how we can bring lab-based testing technologies into the integration conversation to better support across our HIV and TB programs, as well as ideally hepatitis and STIs. And so bringing in all of these components, the guideline group felt like we should make a good practice statement saying that disease programs, especially HIV and TB, should actively work towards balanced integration of diagnostic services. And this seems to be even more important in the current day and age as COVID has really affected some of these programs and really encouraged the use and the sharing of integration across the board. And so with that, I just want to point you at a couple of documents when I talk about the infant diagnosis algorithm. The first two documents on the left-hand side really touch on some of those key considerations that I discussed. And then on the right is the clinical guidelines that were released a couple of weeks ago. The service delivery guidelines should be coming out in the next few days, and I'll be sure to share with yourselves and ASLM for onward dissemination. And with that, I just want to thank everyone that was a part of this conversation and of the guideline process, and turn it back to you, Anafi. Thanks so much.
Thanks a lot, Lara, for condensing the guidelines so succinctly. Colleagues, keep your questions and comments coming through into the chat box, and we shall be taking them as they are coming along. the science has spoken, guidelines have come through. I want to call upon Moses. Moses is an ASLM ambassador, as well as a PA educator who is based in Kampala, Uganda. And Moses wants to speak with the voice of the patients, the voice of those that receive care. Moses, are you there? Oh, Moses kept on dropping a little, and hopefully we will have him coming back. It looks like his internet is a challenge. So whilst Moses is coming, I want to pick some of the questions that are coming through into the chat box. And I'll start here, the one from Pascal, who says, why is there a preference in accessing sites? I guess this is for POC sites. Are they located in more populated areas? It will be interesting to understand the determinants of preferred attendance to particular clinics as part of anticipating optimized placement for POC instruments.
Great, so I can try to answer that. I mean, I think from our standpoint, it's really about country preferences and their consideration and thought in terms of how they want to implement point of care testing. I think in some settings that we've seen thus far, the goal has been to try to impact and affect and reach as many infants as possible, or as many people living with HIV as possible. And typically then that means targeting higher volume settings. Of course, other countries might also want to take into consideration perhaps a lack of access to lab-based testing if you have really remote settings. But of course, then that generally means you have less patients attending and perhaps have less impact. We don't necessarily suggest one or the other at this stage, and really would like to probably more so hear from countries as to what has worked best. But again, ideally, reaching as many, whether it's infants or people living with HIV, is ideal. And thinking through that network optimization that I know ASLM has been working on quite a bit of late will really help think through that. And perhaps there's a combination of the different scenarios that would be most useful.
Thank you, Lara. And talking about combination of different scenarios, we've heard also, people sort of encouraging using alternative entry points, particularly in maybe child nutrition points, MNCH, things like that. Maybe any more comments around that?
Yeah, and I think that's really important. There are a number of different sites within a healthcare facility that could utilize same-day testing, whether it's the TB program, like you said, some entry points like malnutrition, ART, PMTCT. Ideally, it would, we'd try to have a comprehensive approach to make sure all of those different programs are served. And so where that fits best within your healthcare facilities is really, I think, a conversation with them. If a technology is in the PMTCT site, how can we make sure that the adults can still access them for viral load testing, for example, or the TB clinics? And if it's in the lab in the healthcare facility, how do we make sure that the results are still provided on the same day? Because that's really the benefit in having the delays, having the caregiver or the person living with HIV go home is where we really start to see some of the delays happen. So it's quite a tricky, I suppose, implementation consideration about that cooperation and discussion across the different settings.
Thank you, Lara. That's quite interesting. And I'm happy you are touching also on the subject of diagnostic integration and how best this is done. You rightly point out if the instrument is in the MNCH setting, what sort of integration opportunities are you looking at? Are you thinking of HPV, or maybe if it's in the lab, are you also now thinking of TB? How this works? I think these are also important considerations to be taken through as well. I'm glad Moses is back. Moses, can you hear us?
Yes, I can hear you.
Yes, thank you, Moses, for keeping on trying and coming back. Moses, the guidelines are out here. What does this mean to you? What does it mean to fathers? What does it mean to mothers? What does it mean to anybody who needs to access care?
Thank you so much. First and foremost, I want to thank and appreciate the great work that is being done by WHO all over the world. And we are so proud of you. On behalf of the 37 million people living with HIV globally, we appreciate and proud of you, WHO. Now, I've just gone through the presentation by Lara and also happened to read through the document that you sent to me. And have some three or four comments on behalf of my community. First and foremost is the target. The recommendations say that the target is primarily for the givers and not me, the receiver. Now, when it comes to prevention, it's me, the patient, who determines the substantial risk, not the health worker. I mean, it's me who will tell the health worker that I'm actually living in a polygamous marriage, therefore I need a ring. So I would just request WHO, LabCoP, and African Society for Laboratory Monitoring that they need to find best ways of bringing these messages down to the grassroots community in a rooted language, not the media app and so on. Now, the current point of care infant diagnosis cost stands at $15 to $25 per test. That is too high and still unacceptable. We can't accept that. And I think this should be one area for WHO to do some kind of advocacy. We need the cost to go down because we know when it's down, more people access the intervention. Now, resistance testing, you will correct me if I'm wrong. Currently, I cannot access resistance test before my viral load clicks at 1,000. And does this imply that I'm not infectious before 1,000? And if I'm infectious before 1,000, it's also high time that WHO looks at the possibility of putting down the scoreboard to something like 500 viral load, not the 1,000. And does WHO also have an adherence intervention guidelines? And I would really love to know, when did we last update them? We need to know. As per the UNAIDS report, the last time report, they say we are doing very well at the first 95 and second 95, but the world is doing poorly at the third 95. I think we need also to update these adherence intervention guidelines. When the guidelines say point of care viral loads may be used to monitor treatment, it gives the manager room for reluctance. Therefore, I request WHO that in future guideline communication, they can use the word must instead of may. I just read the priorities for point of care, for viral testing. They are well stipulated, but there is that word should instead of must. I mean, when it's must, it's really a word, it's like an order from above. Thank you so much.
Thank you very much, Moses, for the important insights. And I liked particularly when you discuss about the bottleneck for costs. I'm glad Lara presented that whilst point of care shows as if there is, it is of the higher, I think, cost. I think when you now look at cost per result utilized, it becomes a little bit more efficient. And Gonfa, Ayana, Gonfa, thanks for tuning in. Also says, has there been adequate efforts made at the international level to reduce the cost of POC for testing for viral load and EID? And I look at colleagues within the IDC. I see George is here. that I think efforts really are being made to try and see if these costs can be lowered by really coming all together and really speaking with one voice. I don't know whether, George, you have any additions there to speak on behalf of the IDC. All right, looks like I think is on mute. So moving on, I think the questions are coming through. We'll get back to the questions also on costs. Quite an active discussion going through. For example, Frank is saying the only way we can reduce costs for POC, the only way we can reduce costs for POC and provide more country ownership is to introduce manufacturing partnerships. Interesting suggestions coming through there through PPPs, so that most countries can bypass these importation costs and allow ease of availability within the country. Interesting insights indeed. Mindful of the time, Lara presented these elements in 3. She talked about the issue of point of care, viral load, and point of care EID. She also spoke about treatment monitoring and treatment failure. And I see quite a number of these points coming through here where Lara, you had to clarify what is treatment failure, what is detectable, and what is below threshold. Heward Bogale says, what about the implementation of U equal to U for those patients with viral load of less than 200? Do we need to revise the implementation guide? What is your advice?
So that's a good question. And this is something that came up during the guideline session. And just to clarify, the treatment failure threshold was never meant to be ubiquitous with undetectability or untransmissibility. And that's why we determined and decided to bring out a undetectable threshold to try to clarify that they're not one and the same. They shouldn't be considered one and the same. So treatment failure at the 1,000 copies per ml is meant to be very specific for that rationale, when to indicate that someone should be or could be switched to the next regimen. However, we did feel it was important to more clearly clarify what undetectable meant. And this might be a little bit confusing, and we're starting to work with partners about how to better define this. The group really felt that, I know the conversation around 200 copies per ml has come up. That's primarily from one of the studies that was released a few years ago, one of the PrEP studies that showed a lack of transmission when they used that threshold. And that was a pre-study determined threshold that was developed. What the group felt was necessary was, when we talk about undetectable, what truly is undetectable? And they felt that an undetectable viral load was the result there. If you have less than 200 copies per ml, that could still mean that you actually still have virus. You could have a viral load of 180 copies per ml, for example. And so they didn't want to indicate that that equals undetectable because you had detectable virus. And so that's where that move towards the 50 copies per ml, or the less than, effectively whatever comes off the instrument as saying undetectable, is truly what an undetectable is. So we will continue to work with others around developing that. That is the goal, as Supercharger mentioned, for people living with HIVs and for clinicians to try to achieve. And we really want to encourage that, ideally, having no virus in your viral load sample is exactly the goal that we're seeking.
Indeed. Thank you, Lara, for clarifying that. Indeed, having no virus in your sample is the goal. And picking up on that comes in the role of the technology in use as we are measuring this viral load. And I want to pick up on the question from Elizabeth Campira, who is asking, if you assess the probability of EID results error produced, especially using DBS, And I remember, I think, Lara, maybe you may also want to speak to the guideline on technologies, alternative technologies to plasma.
Good, and that was one that we did nicely with ASLM, I believe in 2019 was released. And the goal of that document was to essentially provide alternative technologies and sample types for when countries perhaps cannot do the traditional plasma viral load testing. And dried blood spots was one of those. Point of care was another. And when we say point of care, I just want to also highlight that you can have what are called near point of care technologies. Really the end goal that we see for these types of tests is to provide the result on the same day. Of course, you can implement them in a very different way where the turnaround time may not be same day, and it could be a week, could be a few days. We actually don't have evidence yet to suggest whether that has the same impact as that same day result. So we really want to encourage even near point of care technologies to try to implement them in such a way that that result comes back on the same day. When it comes to the Gene Expert EID test with DBS results, my understanding, and I believe we have some Cepheid representatives on the call and they can speak up, is that that technology and sample type has pre-qualification and can be used for infant diagnosis. And of course, that means that our pre-qualification team is following closely with any potential errors or end user issues. From what I understand, we haven't come across those at this stage, but of course others can speak up probably more keenly on this topic.
Thank you very much, Lara, for those insights. Still moving on, coming back again to the mid-section of your presentation around treatment failure. Michael says drug resistance testing, though extremely useful, sometimes acts as a bottleneck to regimen switch given the time lag. How have the guidelines addressed this for those infants failing treatment?
So drug resistance is an important issue, and I'm glad you raised the question. I think for infants and even for adults at this stage, we're now getting to the point where the utility of drug resistance is perhaps a little less clear. Of course, like you said, it's quite expensive. The infrastructure is not so easy to implement and maintain. But luckily, we're running into an issue, or we're coming to an issue where the drug regimens that are available, both for infants as well as for adults, are based on an optimized drug called dolutegravir in particular that seems to have very low, if no, drug resistance at this stage. So typically, if we see people living with HIV who have an elevated viral load, likely greater than 99% of the time, that is caused by adherence issues. And so the utility of drug resistance in that context, we're still looking for more evidence. Of course, that doesn't mean that it's never going to happen or can't happen, and we need to be ready for that to be the case. And there is some consideration in some settings to perhaps consider drug resistance testing for those patients on dolutegravir who have persistent viral loads. But again, it's really important to ensure that you monitor that their adherence, that you're providing strong adherence counseling. And I know that there have been some questions there talking about that a little bit more. And Supercharger brought it up as well around some of those guidelines, and definitely worth reviewing and reflecting on. But at this point, we don't yet recommend personalized drug resistance for many of the reasons that I highlighted.
Thank you, Lara, once again. There is this question from Chinda Goma. He or she is asking whether there is proficiency testing in TB and EID testing. And I want to sort of also modify that and speak to the last bit of your presentation, which talked about diagnostic integration. And this is one example of whether this, you mentioned that there was a sort of a conditional sort of practice statement that was given that HIV and TB could come through. I think a bit of, for those that are just joining through, I mean, just to clarify exactly what does it mean? What are we really sort of calling for here in terms of not only instruments, but the systems as well?
Yeah, and integrating those systems, we feel, and it's really come to light over the last couple of years with COVID in particular, the consideration and sharing of those networks that exist. I think sometimes we've seen, for example, multiple sample transportation networks being developed, one for HIV, one for TB. Now we're starting to see perhaps one for hepatitis or one for cervical cancer. How can we start thinking about that type of integration? And I think the point was raised around also quality assurance. Many of the components within all of these different systems are very similar across the different diseases. They're not exact, and we shouldn't think they're necessarily exact. We may need to make some tweaks to one or the other, and TB sample transportation is one of those in particular, given it requires a little bit more biosafety considerations. But there are efficiencies and savings that can be realized with that integration. And Anafi, I think at least on the quality assurance aspects, you can likely speak more to that and the availability of those specifically than I can.
Indeed. Thank you, Lara, for raising those points, particularly around integration and the possibility of sharing program costs even from regulatory point of view, even from policies to training to system issues, sample transport. Sometimes it's the same human resources that are coming through. Data management, the connectivity will still apply to the same things. The trainings, most of the time, it's really similar methodologies, but just slight differences. Even supply chain, service and maintenance will also come through. So indeed, it's all about efficiencies coming through as we try to call upon integration to come through. I know the time is almost gone, but there is one interesting question, Lara, that is in the chat box, and it's from Kenneth Maeka. And he's talking about an interesting subject that is always come through, particularly when it comes to technologies, indeterminate ranges. Of course, he has brought it in terms of how is the progress in implementing an indeterminate range for POC as we do for standard of care.
Very important question. I think this one's important in particular to ensure as simplified a strategy as possible for end users to reduce the amount of interpretation that's required. We've been working with each of the different suppliers in terms of trying to implement this within their technologies. We do actually have, beyond these two guidelines that we're just releasing now, in the middle of this year, we'll be releasing consolidated HIV guidelines. So we're taking a look at all of those previously from 2016 and even before, and really bringing it all together, everything that's also been done in the interim, so that it's a little bit easier to find all of the most relevant recommendations to date. Within that, we'd also like to provide an update to the 2018 indeterminate range recommendations. And we'll be continuing to discuss this with all of the different manufacturers to ideally have those incorporated within that guideline. So hopefully that will provide some, and we'd also be interested to hear from countries how it's gone in terms of implementing that recommendation in general as well.
Okay. Thank you very much. You know, it's so difficult to end as you see interesting questions. I think there are so many perspectives coming through: integration of HIV, EID viral, COVID-19, TB testing, you know, coming through. And we hope, I think we'll probably need more sessions around this subject as you can see the questions coming through. And so hopefully we could be organizing some coming through. I want to just, as we are about to close, call back Moses. Moses, any last parting words in 30 seconds? Supercharger.
I just want to thank you and thank Lara for the great presentations. And also wanted to know the composition of the guideline development committee. I'm really interested to know whether there is an element of community in it. A question to Lara. Yeah.
Thank you, Moses. Within his remarks, he had a question for you, Lara. So as you are closing, please also address this.
Great. So first, I just want to thank ASLM for the opportunity to present here today. I think this is really useful. We're very keen to support and coordinate with ASLM to disseminate these guidelines. Please feel free to reach out to them or ourselves if you have any additional questions. And it's a great question that Supercharger asks in terms of the composition of the guideline development group. And generally, in this year in particular, it's quite a mix of participants. Typically, we have quite a number of clinicians. We have, because of the diagnostic focus, we had a number of diagnostic staff, lab staff as well. And then really it's quite heavy in terms of having program managers from key affected countries, and ideally from all of the different regions across the world. And then perhaps most importantly, we have a number of civil society representatives. So people living with HIV, mothers who have HIV, and others to provide their perspectives and be able to support that discussion. So we really tried to bring in a broad range of different expertise in order to support the decision-making, in order to support that we're bringing in the perspectives of all across the board. So thank you again, ASLM and Anafi, and looking forward to your next webinars.
Thank you. Thank you for the wonderful lesson, Lara, and thank you everyone for the engagement and the interesting questions that are coming through. We acknowledge we have not addressed all of them, and we shall go back into them and hopefully use these to also determine which areas to focus in our next couple of sessions. As always, we encourage you to go to the ASLM Academy and be able to download your certificates. We have put the code into the chat box. Please feel free to ask any questions should you face any challenges. Watch out for further sessions that are coming in next week, interesting ones that are coming through. So we shall be sending this through your emails. Watch out in the inboxes. Till we meet next week, and have happy holidays coming through this weekend. Bye-bye.